You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 13th, 2019. This week, this is part 2 of an ESC recap with 5 more studies from the ESC Congress in Paris. And I want to first start by saying thank you to the listener who corrected my pronunciation of the SGLT2 inhibitors. These drugs are difficult to pronounce, so I appreciate the help. Now on to the studies. First up is a study on double versus single therapy in patients with AFib and coronary artery disease. Almost every day a cardiologist will see a patient in clinic who has AFib and is on a direct-acting oral anticoagulant or DOAC, but has had a PCI in the past and is also on an antiplatelet agent. Now everybody agrees that immediately after the PCI, you have to use multiple antithrombotic drugs. But what about after a year? Can we stop the antiplatelet drug and go with the DOAC alone? This was the question of an RCT done in Japan called AFIRE, A-F-I-R-E, and it was presented at ESC and published in the New England Journal of Medicine. It had about 2,200 patients and randomized to either rivaroxaban or rivaroxaban plus antiplatelets. 70% of the patients had had previous PCI in the distant past, 11% CABG, and the rest just had coronary disease. The primary endpoint was a typical composite endpoint of stroke, systemic embolism, MI, unstable angina, and death from any cause. The primary safety endpoint was bleeding. As Steve Stiles, who has brilliant news coverage of the trial, called it, AFIRE did have some important quirks. Rivaroxaban dosing was 15 milligrams daily, not 20. Now that's the approved full dose in Japan because pharmacokinetic studies shows that it delivers equivalent plasma concentrations seen with the 20 milligram dose in Caucasian patients. And another quirk, among the combination therapy, about 70% were on aspirin and 27% received a P2Y12 inhibitor. And the results, the monotherapy group did much better. The primary endpoint occurred in 4.1% versus 5.8% for the combination, and the trial was stopped after 24 months due to this difference. Death was one of the drivers of the primary endpoint. Overall death, 1.9% in monotherapy, 3.4% in the combination arm. The primary safety endpoint, or bleeding, also favored the monotherapy arm, 1.6% versus 2.8%. So AFIRE adds to the less is more theme for prevention of thrombotic events in patients with AFib and coronary disease. The Pioneer AF, Redual PCI, and Augustus trials all suggested that dual therapy rather than triple therapy in the first year after PCI is better, but again, what to do after 1 year is less clear. A previous trial called the OAC alone trial attempted to study the oral anticoagulation alone after 1 year, but was stopped for slow enrollment, so that study did not have the power to inform us. AFIRE strongly suggests that monotherapy after 1 year is preferred, but I think we need confirmatory trials to be sure. For instance, a trial with rivaroxaban at the standard North American dose would add confidence, and trials with other DOAC drugs alone would also help. Keep in mind, too, here that 30% of the patients in this trial, a AFIRE trial, did not have a PCI, and a quarter of those who did had a PCI with bare metal stents. So if you enrich the population with patients less susceptible to the need for antiplatelet drugs, it may make DOAC monotherapy look better. Would monotherapy perform as well in a patient population, all of which that had stents or all of which that had drug-eluting stents? That is a question that I don't know. Second topic, text messaging as a health intervention. So simple, low cost, and automated. These are the modifiers for a text messaging program for patients with type 2 diabetes and coronary disease in China. The RCT was called ChatDM. It was performed in 34 hospitals in China, and it pitted an intervention group that had 6 text messages per week versus a usual care. The primary endpoint was a change in hemoglobin A1C from baseline to 6 months. The authors boasted 99% follow-up of the 500 patients in this trial, and the text messaging group did better. They had a greater reduction in hemoglobin A1C and a greater proportion of participants who achieved hemoglobin A1C less than 7. Changes in fasting blood glucose favored the text messaging group. Now, nearly all participants reported that the messages were easy to understand and useful. Circulation Outcomes published a paper, and I talk about it on a podcast for a couple of reasons. First, the effect size of lowering the hemoglobin A1C with text messages is similar to that what we can get with older hypoglycemic agents. This trial is also a bit novel in that it targets high-risk patients that have 2 conditions, and it was done in a low to middle income country. The text messages were also well received by the study participants. Also notable was that the text messages did not require extra personal contact or investment from healthcare professionals, and the authors write that the simplicity of the intervention lends it to the potential for scalability. Finally, these types of intervention studies are the beginning of a new way of delivering healthcare. Some of these will be successful, but others will not. For instance, the BEAT-HF trial of health coaching, telephone calls, and telemonitoring did not reduce readmissions in patients with heart failure. However, the Chinese and American authors on this paper were very forthright in listing their study's limitations. For instance, they say that the text messaging did not improve BMI, blood pressure, or LDL, and their study did not measure outcomes, which of course is the ultimate goal. But I highlight this because it's a nice beginning, and gosh, it is refreshing to see digital health interventions face the RCT test. Third topic today are high-sensitivity troponins. 2 hotline trials at ESC inform the use of high-sensitivity troponin in emergency departments. One study from Scotland looked at a single high-sensitivity troponin I measurement, and another from Australia studied a 0 to 1 hour protocol using troponin T. Now, I spoke with Nicholas Mills at ESC, and he is one of the senior investigators of the historic trial from Scotland. Our interview is up on the heart.org Medscape Cardiology site. The historic trial used a stepped wedge cluster design, and randomization was at the level of numerous hospitals, not the patient. So this approach is noteworthy because it ensures consecutive enrollment of patients without selection bias. 3 quick background points. One is you already know, high-sensitivity troponin allows measuring troponin in the majority of healthy people. Second, Professor Mills's group has published a high-stakes trial last year, and that showed that the use of high-sensitivity troponin assays compared with the conventional assay prompted reclassification of 17% of patients with myocardial injury or infarction, but these reclassifications did not associate with the lower rate of MI or CV death at 1 year. Thus, there is a need to develop new approaches to risk stratification and early rule-out pathways. In the historic trial, the investigators used this high-stakes early rule-out pathway, which is used for patients whose symptoms have been ongoing for greater than 2 hours. That's an important point. And it turns on a single troponin measurement. The investigators aim to define the optimal risk stratification threshold to rule out MI with both safety and efficacy as the 2 goals. Now, the high-stakes early rule-out strategy has 3 pathways. First, if the high-sensitivity troponin is less than 5, then the patient is low risk and referred as an outpatient. If the high-sensitivity troponin is greater than the 99th centile, then the patient is high risk and admitted for inpatient testing. And if the initial high-sensitivity troponin is between 5 nanograms to the 99th centile, then the risk is intermediate, and a retest is done in 3 hours with adjudication depending on that. In the end, approximately 15,000 patients were evaluated with a standard care pathway and 15,000 evaluated with his early rule-out pathways. And they had the co-primary endpoints were length of stay and MI or death at 30 days. And they found that the early rule-out pathway reduced length of stay by 3.3 hours and increased discharge from the ER by 57% in relative terms. And the primary safety endpoint, MI or CV death at 30 days, occurred in 0.4 in the standard pathway and 0.3 in the early rule-out, and these numbers are obviously numerically similar, but that did not meet non-inferiority due to the upper bound of the credible interval. However, in the secondary endpoint of adverse events at 1 year, there were no significant differences in MI or death. Here, the hazard ratio was 1.0. Now, adherence to the early rule-out pathway with a single troponin was up to 90% in these emergency departments, and it allowed the authors to conclude that the use of the early rule-out pathway, which incorporates a single troponin with separate risk stratification and diagnostic thresholds, was more effective than using the 99th centile and serial testing from 6 to 12 hours from symptom onset. And 3/4 of all patients with suspected ACS were managed in an outpatient setting, and these pathways reduced the emergency department length of stay and increased the proportion discharged from the emergency department, and the implementation of the pathway was safe and effective. Now, ESC also had a second study on high sensitivity troponins, this one from Australia called the Rapid Troponin T study. Here, the authors were interested in the clinical impact of the improved diagnostic precision of the high sensitivity troponin T when it was incorporated into a rapid 0 to 1 hour protocol. Now, a key thing was that the 5th generation troponin T was introduced in 2011, and it became the sole troponin assay in public hospitals in South Australia. But soon there was a concern about higher rates of abnormal troponin results and an increase in invasive testing. So the reported upper limit of normal 99th percentile was aligned to the 4th generation level, which was 29 nanograms per deciliter, even though this newer high sensitivity assay was equivalent at 44. The local emergency departments in this study remained masked or blinded to the troponin T below the 29 nanogram to deciliter level. Troponin levels below that were not reported, and clinicians therefore had no prior experience with high sensitivity troponin Ts below this level, and that was important for the study because you want to know how the protocols compare in contemporaneously enrolled patients in which the only difference was the protocol. So the Rapid Troponin T study was a prospective in-practice RCT conducted in 4 public emergency departments in Adelaide. And it tested the non-inferiority of a 0 to 1 hour protocol compared with the 0 to 3 hour protocol in patients who presented to the ED with suspected ACS. Patients were first assessed by history, then an ECG, then they were consented. Then they were randomized to a 0 to 1 hour protocol with the high sensitivity troponin versus the standard protocol with the masked troponin levels if below 29. Randomization occurred before the troponin levels were known. Obviously, patients with STEMI or high-risk patients were excluded. Now, the 0 to 3 hour protocol is standard. Troponins greater than 29 in this protocol, or patients who had known coronary disease or ongoing chest pain were admitted. Patients less than 29 were discussed with the consultants. That was the standard. The 0 to 1 hour protocol had 3 options. Patients ruled in if the troponin was greater than 52 or the delta at 1 hour was greater than 5. Patients were observed if the first troponin was 13 to 51 or a delta of 3 to 4, and patients were ruled out if the high sensitivity troponin was less than 5 or the baseline troponin was less than 12 and the delta was less than 3. And then there were suggested managements. For rule-in was cardiology consult, for observation was another troponin in 4 hours, and a consultant with the on-call doc, and for rule-out was discharge from the ED and follow-up in outpatient setting. They randomized about 3,400 patients over slightly more than 3.5 years. In the standard 0 to 3 arm, about a third of patients were recommended for admission and 2/3 for discharge. But in the 0 to 1 hour protocol, 8% were ruled in, 19% observed, and 72% ruled out. Now, in the emergency department, there were no differences in MI diagnoses, and the primary endpoint was 1% in both arms, so no difference. The diagnostic performance of the 0 to 1 hour protocol depended on whether it was positive or negative. If you ruled in, the positive predictive value was only 38%, but amongst those discharged and ruled out, the event rate was only 2 in 630, or 0.3%, which is a negative predictive value of 99.6%. And participants who were in the 0 to 1 hour arm were more likely to be discharged from the emergency department, and their ED length of stay was shorter. Those randomized to the 0 to 1 hour protocol were also less likely to undergo functional cardiac testing. The rapid protocol, however, led to more revascularizations within 30 days, 2.2% versus 0.9%, and this was likely due to an increased detection of myocardial injury or infarction in the subgroup with a low initial troponin of less than 29. These findings allowed the authors to conclude that patients classified as rule out are safe for early discharge and have a low rate of death or MI within 30 days, and this supports the routine implementation of the 0 to 1 hour protocol. Implementing the 0 to 1 hour protocol, however, does not improve the diagnosis of MI, though the authors said that their 12-month analyses are pending. The authors expressed concern about the increased use of invasive angiography among patients with newly identified low levels of troponin T, and they called for further studies on whether or not these increased interventions cause harm or benefit. Now I know, that's a lot of stuff, so my take home. Whenever a high sensitivity troponin study comes out, I literally spend hours sorting through the complicated algorithms and details. Ultimately though, no matter the sensitivity of a troponin assay, we're likely never getting to a negative predictive value of 100%. In the Australian study, for instance, 2 of 600 patients were ruled out and discharged but had an event. And until we agree on the acceptable number of misses, and it can't be 0, I think we'll continue to find incidental coronary artery disease that is, by definition, overtreated with PCI. The last topic today is an ICD study at ESC. This was a registry-based study presented at ESC, and it garnered attention, and some key opinion leaders even suggested that it confirmed the decades-old trial findings of ICDs. Now, I disagree, and once again, I highlight the study because there are specific and larger lessons for the evidence-based clinician. Researchers from Sweden used the Swede Heart Failure Registry to compare 2 groups of patients with heart failure with reduced ejection fraction. Those patients whose doctor chose to put in an ICD, and those patients who did not receive an ICD. Now, the Swede HF is a registry of in or out patients with heart failure from Sweden from the years 2000 to 2016. The total cohort eligible for the study, based on guideline criteria for ICD implantation, was about 16,700. Slightly less than 10% of these patients actually got an ICD. The other 90% did not get an ICD. So now comes the tricky part. The authors then took the 1,600 patients who had an ICD, and they found 1,600 patients who didn't have an ICD to compare them to. They used the national database to measure the primary outcome, which was 1 in 5-year death rates. The first paragraph of the results shows the problem with the non-randomized comparison. The authors write, quote, "Most of the baseline characteristics were differently distributed in ICD recipients versus non-recipients." Now, of course, the authors used propensity matching with 30 variables in an attempt to make the groups similar. But of course, you can only match variables recorded on a spreadsheet. Many intangible variables go into the choice of using an ICD or not. And the results of this registry study were quite positive for the ICD. Patients with an ICD had lower mortality at 1 in 5 years. The authors even did a negative control analysis and found that 1 in 5 year risks of hospital admissions for other diagnoses like renal failure, COPD, pneumonia were similar. And this is a statistical tool that strengthens the argument that the propensity matching was successful in getting the groups to be similar. But two peculiar findings. One was that the ICD effect seemed to attenuate after the first year. This is peculiar because seminal ICD trials have Kaplan-Meier curves that separate after 1 to 2 years, and the ICD benefit extends many years. Also strange was the subgroup analyses. While none of these subgroups met significance for interaction, the hazard ratio for ICDs was 0.5 in the non-ischemic arm and only 0.78 for ischemics, and that's opposite of what has been found in previous studies. And previous studies showed much greater benefit for the ICD in ischemic cardiomyopathy. Also, the ICD looked better in patients older than 75 versus those younger than 75. Again, this is opposite to what we see in the Danish trial, which found benefit for the ICD in younger patients, as expected since younger patients have fewer competing causes of death. Now, these peculiarities of the data suggest that this observational analysis suffers from the fatal flaw of nearly every non-randomized observational cohort, and that is selection bias. Propensity matching on 1,000 variables from a spreadsheet cannot account for unmeasured confounders, like general condition of the patient, social status, depression, family support, to name just a few. So you can only conclude an ICD is better if the comparator groups are randomized. And the last time this was done in Danish, and the ICD did not improve mortality. What's most remarkable about this study is how its top-line results can be used to uphold ICD benefit and downplay the Danish trial. I respect the work of Drs. Al-Khatib and Kusamoto, and they are nice people, but I strongly reject their pro-ICD arguments in the accompanying editorial. They cite observational data, dismiss Danish, and laud this Swede HF registry. Editorials such as these are problematic because a reader of circulation gets no opposing view. Thus, I highlight the Swede HF study for its specifics. For example, this data does not change the notion that ICDs look a lot less beneficial in the background of current heart failure therapy. And I highlight the Swede HF registry for the larger issue, and that is observational data, however large, should not be used to make therapeutic decisions, especially when RCD data is available. Finally, almost every ICD lecture I give starts with a Mark Josephson quote. And the quote says, "Don't believe everything you read in the EP literature, or at least don't believe the interpretation of the results and conclusions drawn. It is not etched in stone like the 10 Commandments." So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And if you like this podcast, please consider telling a friend or subscribing and giving us a review on whatever podcast app you use. This helps people find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.